So the second section about chest ultrasonography. The ultrasonography of the lung has developed a lot during the last decade with the production of much scientific literature over the past 5 years. Nevertheless, as you can see, the sacred text of medicine not yet accept the opportunity to be able to evaluate with ultrasound an organ such as the lung. In fact, in 1992, the Harrison, this is sacred text of medicine, said that the hair is an important barrier to use the ultrasound for lung study. And in 2001, the ultrasonography is not useful to evaluation on the lung tissue. Only in 2005, the Harrison said that because ultrasound energy is rapidly dissipated in the hair, ultrasound imaging is not useful for the evaluation of the lung parenchyma. However, it is helpful in the detection and localization of pleural abnormalities and is often used as a guide to placement of a needle for sampling of pleural fluid liquid, thoracentesis. So, on the other hand, also this affirmation, which will come in clinical practice, I am extremely doubtful, because the clinical application takes a long time and good amount of difficulty to the patient and the doctor, was said by John Forbes in the introduction of the Treaty of the Laennec in 1823. About what? About what? About stethoscope. So why chest ultrasonography? It's impossible, the mistaken belief that it's impossible to explore the lungs with ultrasound because the eye content isn't right, because in reality we can see the paradox of the lung, whereby the lung is a little accessible when it's normal, but show specific patterns when it's affected by disease. The word stethoscope originated in the early 1900s from the Greek stetos, chest, and scope, observation. In fact, we observe the chest. We don't escort the chest, we observe the chest. Some reminders of the anatomy of the normal lung. Okay, you can see the trachea, the main bronchi, and under the skeleton rib, you can find the pleura that envelopes the lung. The pleura is formed by a parietal layer adherent to the ribs and visceral layer adherent to the lung. The virtual space between the two pleura is the pleural cavity. Okay? What kind of probe for chest ultrasonography? Generally, we can use all three probes, but as we will see, some kind will be dedicated to the specific area of the lung. Prevalently, we use the linear probe and the convex probe. The chest scanning technique is performed by a longitudinal scan along the parasternal, midclavicular, anterior axillary, posterior axillary line in patients that lie in this position. Example for trauma patient. If the patient can sit down, we can evaluate also the posterior axillary line. The scan allows you to get an overview of the entire lung. Then we can evaluate particular pathological scan with longitudinal or transverse scan. But you must begin with the longitudinal scan. Basically, we can recognize in the normal lung three structures: the chest wall, the pleural line, and the lung parenchyma. In the chest wall, we can identify the skin with the subcutaneous fat, the pectoral muscles, and the ribs. In this case, the ribs are crosswise, are cut crosswise. This is a ribs. This is the shadow of the ribs. This is the intercostal muscle. So, subcutaneous fat, pectoral muscle, intercostal muscle, one ribs, two ribs, and this is the shadow. This is the pleural line. The pleural line has an hyperechoic line. It's composed by two pleural layers that slide on. This movement is called gliding or sliding. The pleural line is for us, for the ultrasound, the pleural line is like a mirror. Is like a mirror where behind is projected due to reverberation mechanism the chest wall. This is the pleural line. The horizontal reverberation that form are called E-line. This is the E-line. The E-line are placed at the same distance from the pleural line. This distance is the same from the superficial to the pleural line that reverberate in the parenchyma. So, the lung parenchyma in a normal lung is only the E-line, the reverberation of the pleural line with the E-line. This is a normal parenchyma of the lung. This is a summary diagram of the normal lung. This is the pleura that have gliding. This is the E-line. And this is a clip. This is a clip of the normal lung. So, ribs. This is the pleura, the gliding of pleura. In B mode, it's easy to see the gliding of the pleura. Okay, this is the E-line, this is a subcutaneous fat, this is a intercostal muscle. In this slide, you can see the microorganization of the lung. The lung is organized in secondary lobules with their pulmonary, arterial, and vein. The lobules are divided by means of septa. So, all the pathophysiology of the lung begin with the involvement of the interlobular septa. This. The interlobular septa that can be thickened or be thickened or full of fluid. For example, fluid during an inflammation of the lung, or during the early stage of the acute cardiogenic pulmonary edema. The fluid stays in the interlobular septa and seems to be thickened, seems to full of fluid. Subsequently, I've involved also the intralobular septa, this is intralobular septa, and then the alveoli. Hand in hand, that the lung loses the high content and becomes a parenchymal organ. The lung is an organ with a lot of hair than 70%, 20%, 5%. Become a parenchymal organ, such the spleen, such the kidney, such the liver. In fact, we talk about of hepatization of the lung. The lung pathology, in the lung pathology, we can divide the lung ultrasound pathology in two patterns. The interstitial alveolar pattern with the B-line and the high space pattern with the consolidation. Now we see the B-line and the consolidation. We say that the pleural is like a mirror for the ultrasound. So, when the mirror is broken behind the pleural line, we can see some artifacts. These first artifacts are the B-line, or called comet tail. The interstitial syndrome. This is a movie of the lung with the initial interstitial syndrome. Okay. This is, dov'è? Ecco qua. This is the B-line, okay? The B-line are defined as discrete laser-like vertical hyperechoic reverberation artifact that arise from the pleural line. Previously described the comet tail, as I said. Extend to the bottom of the screen without fading and move synchronously with the lung sliding. If there is no the lung sliding, there is no the B-line, okay? B-line are artifact, only artifact. The anatomic and physical basis of B-line is not known with certainty at this time. The interstitial syndrome can progress to more severe from when the same also involve the intralobular septa. Interlobular septa, alveoli. Sonographically, we can distinguish, so, black lung, black-white lung, and white lung. This is an example of cardiogenic alveolar interstitial syndrome. This is an example of white lung reported to cardiogenic alveolar interstitial sound. As you can see, the B-line are compacted, fused, combined. This is the B-line that are compacted. This is the ultrasound white lung, that is different from the X-ray white lung. When the pleural line is like a broken mirror, we have the lung consolidation. This is a diagram that shows a consolidation. We can recognize the B line and the C line. C line which have the same meaning of B line, but arise from the consolidation. It's the same meaning, but are called C line because arise from the consolidation. This is an example of pulmonary consolidation. The lung that when is normal show only the E line, when there is a consolidation appear like a parenchymal organ, like liver. This image is similar to the liver. The main feature of the pulmonary consolidation are low echogenicity and ecotexture in homogeneous, consensual movement with the breath. You can see the movement with the breath of the patient. The consolidation can a polygonal lesion or oval lesion. The edge of consolidation are often irregular and indistinct, and we can find a dynamic eye bronchograms in 97% of cases of infection, consolidation as pneumonia. The dynamic eye bronchogram is in the consolidation pneumonia. This is an example of eye bronchogram with the eye that flow into the bronchus. The hair is white, okay? In ultrasonography, the hair is white. So we see the hair that flow into the bronchus. In this movie, you can see an initial hepatization of the lung in the left. So this is a rib, okay? The shadow. In the left side, there is an hepatization of the lung. In the right side, the hair arrived, and we see a movement with the breathing. But in this side, in this part, there is no hair into the lung. So this is like a liver. The atelectasis have, contrary of the consolidation, have an homogeneous echogenicity comparable to the liver. There is no high bronchograms, okay? In hepatization lung, we can see the bronchial vessel because the lung become like a liver. This slide summary show how the ultrasonographic lung patterns change based on the amount of the air present. So, 98% normal lung, 95% the B line or compacted B line, like a white lung. The consolidation, and finally the atelectasis with only 5% of air of content in the lung. Let's see the pleural pathology. So we can distinguish pleural effusion divisible in transsudate, empyema, and hemothorax. The pleurisy, the pulmonary embolism, and the pneumothorax. And we tell about the pneumothorax tomorrow when we tell about the extended fax exam. Okay? What kind of probe for the chest wall and the pleural line? Surely the linear probe is the best probe. The pleural effusion is characterized by the presence of fluid between the two pleural layers, parietal and visceral pleura. This is the pleural effusion. We can use a convex probe that we can put at the level of the posterior axillary line above the diaphragm. This is the point when you put the probe, and you can see this sign that we call the Cartine sign, that consists of the appearance of the lung above the liver in the right side, above the spleen in the left side. The presence of this sign excludes the pleural effusion. This is liver or a spleen is not important in this moment. It is an organ, parenchymal, and this is the lung that arrived and made the Cartine sign. If you have a pleural effusion, you don't see this movement, but you see the pleural effusion. You see the pleural effusion, you see well the diaphragm and the pleural effusion above. Now we see some example. So the pleural effusion is characterized by ultrasonography anechoic space between the parietal and visceral pleura. Sinusoid sign is a variation of the interpleuric distance during the respiratory cycle. We can see this variation. So this is a liver. This is the diaphragm. This is the lung that arrive into the little pleural effusion. This is a little pleural effusion. This is the pleural effusion. When there is a pleural effusion, you can see very well the diaphragm. Okay? Another is the respiratory movement of the lung into the pleural effusion. Okay? This is a pleural effusion. This is a lung. This part of the lung is an atelectasis lung. Probably this is an eye bronchogram. So probably this patient have a pulmonary consolidation with a pleural effusion on the same side, and this is a pulmonary eye bronchogram, and this pulmonary atelectasis of the lung in the pleural effusion. With ultrasound, we can also distinguish the etiology of the pleural effusion. For example, effusion with internal echoes suggests the presence of exudate of blood. This is an empyema. We have an ropey effusion. As you can see, so this is the lung. This is the effusion. But into the effusion, there is filament. This is a rope effusion, okay? Another example is an hemothorax. You can see the corpusculate effusion. This is blood. This scan is made with a sector probe from the posterior. There is a lot of effusion, so you can see also a short axis of the heart, because there is a lot of much effusion with the atelectasis of the lung and the hemothorax. So, the importance of ultrasonography, because we tell about of radiologic white lung. This is a radiologic white lung, okay? This is a chest X-ray that show a radiologic white lung. In which it's hard to understand what is under the white. It's difficult to say what is under the white from the radiological view. But the same chest seen with the ultrasound is this, show pleural effusion and atelectasis of the lung. And this is difficult to say that is only pleural effusion if the lung is atelectasis lung. With the ultrasound, we can distinguish from the pleural effusion and atelectasis. The pleurisy. The pleurisy is characterized by a localized fragmentation of the pleural line. This is an example of the fragmentation of the pleural line due to an initial pulmonary consolidation. The pulmonary consolidation starts under the pleural line and envelop the pleural line. So the pleural line appears with fragmentation. This is the pleural line. This is the fragmentation of the pleural line. This patient have a pleuritic pain. Pleuritic pain, a chest pain that is different from the chest pain of the myocardial infarction. This patient have a pleuritic pain. The ultrasonography is useful to diagnose some findings of the pulmonary embolism. The pulmonary embolism, we can see the pleural multiple hypoechoic lesion predominantly located in the dorsal and basal fields, size from 5 to 20 millimeter. 86% are triangular. 11% are round, 3% are polygonal. Sometimes have a single central echo of residual parenchyma is visible. This is the single central echo of the triangular lesion. Absence of color Doppler flow signal. Sometimes we can find the vascular sign. The vascular sign is this. It is on the apex of the triangle as a sign of congestion in thrombosed valves. We have a pulmonary embolism. So, basal ipsilateral pleural effusion we can find in 61%. This is an example of pulmonary infection. As you can see, this is the pleural line, this is the triangular. This is another example of triangular lesion that involve the pleural line. In the differential diagnosis between the ultrasound images, we have to distinguish also neoplastic lesion. These are two examples of neoplastic lesion. This is a metastasis of the cancer, of the uterus cancer. As you can see, the neoplastic lesion is rounded, polygonal, and involve the pleura and the muscle. And this is a metastasis of breast cancer. Okay. It is different by the normal consolidation. Okay. So, to summarize, we have seen the pulmonary embolism with the aspect of triangular. Sometimes we find this sparing of the pulmonary. Pleurisy, okay? Pneumonia with the high bronchogram and bronchogenic carcinoma or metastasis of cancer. Finally, I want to tell you the chance to evaluate with the ultrasound the diaphragm excursion. We can see a B mode and M mode scan of the diaphragm at the level of the liver. You can see this is the liver, this is the diaphragm. With the M mode, this is the excursion of the diaphragm. This is an example of measurement of the diaphragm excursion. This can be important, for example, to evaluation a respiratory failure or its eventual improvement after therapy, not in an emergency room, for example, in the setting of intensive care unit or in the reanimation. So, but this is more important to see if the therapy that we give to the patient is the right therapy or not. So, the chest ultrasonography in patients with acute dyspnea, it's useful, it's feasible. Since this question was born, this paper. In this paper, we enrolled 1,404 patients, mean age 70 years. All the patients underwent chest ultrasonography and subsequently X-ray. The patient come in an emergency department, and before to make the chest X-ray, we perform the chest ultrasonography. In 118 with mismatch between ultrasonography and chest X-ray, the CT scan of the chest was performed. So this is the result. This is the concordance between ultrasonography and X-ray. We want to find if the chest ultrasonography have the same utility, the same concordance of chest X-ray. For us, it's important because chest ultrasonography is take 5 minutes to time. The chest X-ray, the time is more long. So this is the concordance. That is an high concordance, and the P is this. For pleural effusion, for pulmonary edema, for acute respiratory distress syndrome pattern, for pneumothorax, for lung consolidation, an high concordance. When, in the case of discordance between ultrasonography and X-ray, was performed chest CT, as CT for us is the reference standard. And ultrasonography show and sensibility and specificity respect the X-ray more important for pleural effusion. With ultrasonography, we can detect pleural effusion better than the X-ray.